issues of coagulation testing. Coagulation problems is a common issue in clinical practice. It's an ignored aspect in MBBS and PG curricula. So I remember my own MBBS class as hemophilia, ITP, a bit of DIC, and that was it. And I just asked before the session started if the PGs have done any PT, aPTTs with their own hands. So that answer was no. And that's across India. Most people do not get into coagulation because there's nothing to see really. It's liquid to liquid, some gelling, and that's it. No exciting cells. So coagulation goes like that. And we know that if you think about coagulation, you ask anybody about any disease, hemophilia comes up as first. But remember, acquired coagulation disorders are much more common in clinical practice than any of the inherited disorders. So your liver disease, DIC, sepsis, vitamin K deficiency, and so on, they take up most of your time in the clinical practice. And many inherited disorders are underdiagnosed and misdiagnosed because of lack of knowledge and lack of diagnostics. And automation, getting a coagulometer is not the only answer. We must be aware of the manual techniques. What if your coagulometer fails? You can still do it with a water bath. Absolutely no problem. So I'll expect all the PG residents participating today to please go back and do manual PT or aPTT or both testing with your own hands tomorrow onwards. At least a try. So coagulation requires a good understanding of basic hemostasis. So your vascular channels, your platelets, the coagulation pathway, and the fibrinolytic pathway. And remember, coagulation testing is not as cheap as CBC. It is expensive, goes into thousands at times. So you need a logical stepwise approach to save resources and money for the patient. Most important, the sample integrity is crucial. About 75% of errors in coagulation occur due to pre-analytical variables. A fact that is talked about, but clinicians usually do not agree because if there's a problem, they will hint at a lab, but quite often the sample has the problem. And also remember, when we try to talk about coagulation, a PT, aPTT, TT, or a factor assay, the tube in which we test is not the body. The tube does not have endothelium. So we are actually looking at the factors in a liquid milieu with calcium depleted and then calcium given. But there is no interaction of the endothelium. So although it tells us a lot, it does not tell us the whole story. And please work closely with your clinician to solve his or her coagulation problems. They will thank you for life. Very vital to have a clinician laboratory rapport in this domain and actually all pathology. And history, the most vital component of a coagulation testing and to reach a diagnosis should not be history. Keep at it, keep asking for a good history. You'll get 90 to 95% of the diagnosis only from the history. The rest is only confirmation. So how we plan to discuss today? I had shared 7 cases in advance with the students. And I'll expect students to pick a specific case, and I'll maybe start with names as we begin, and then they can start discussing that case and going towards the diagnosis. Anybody can ask further queries regarding the case that might help in better understanding. And once the case has been presented by the students, I will discuss important aspects, the learning areas, and related areas. So very important to have this pathway in mind. So any coagulation problem with whatever advancements you may be having is incomplete till you sort out this pathway in your mind. What does the PT tell you? What if this factor is missing? Which test will be normal, which will be abnormal, and so on. So this has to be inbuilt in our heads all the time if you have to sort out coagulation problems. We know that the cell-based model has come. That is more complex, answers some of the fallacies of this model. However, this model will help you to sort out most of your coagulation problems even now. So let's begin with the case studies and case 1. So Dr. Preeti, what do you make of this case? A 6-year-old boy with cyanotic heart disease and fever for 3 days. Hemoglobin is raised, PCV is raised, TLC is the mild leukocytosis, platelets slightly on the higher side but within normal limits, and both PT and aPTT are deranged. He has blood tint expectoration also, and because of that, the fresh frozen plasma has been transfused. What is your opinion on this case? Dr. Preeti, please.
Yes, sir. Sir, the hemoglobin is raised, that is 22.3 grams per deciliter. And sir, the TLC is normal. The platelets are also normal. The PT is on the higher side, and sir, aPTT is also prolonged, 54.6 seconds. So, sir, in my opinion, sir, it's a cyanotic heart disease case. So, the patient is in a state of chronic hypoxia. So, and both the PT and aPTT are prolonged. So, I think, sir, it can be a case of secondary coagulation disorder where there is multiple factor deficiency, sir. So because the liver is in a state of hypoxia, as the factors are produced in the liver, so sir, it's a secondary coagulation defect, in my opinion.
Okay. Anybody else wants to have a different opinion? Any other student wants to participate in this case? Okay, you'll respond to names, I believe. Dr. Gifty. Any thoughts?
Sir, I too thought the same, sir. It's an acquired coagulability because of the congenital cyanotic heart disease, sir.
Okay.
So,
Okay.
with maybe an erythrocytosis also included in it because the value is a little increased, sir.
Right. Right.
Yes.
Okay. So let's have a quick discussion on this case. So in the next slide, the same case is there, but I've highlighted the important points to consider. So one is fever, so some infection, cyanotic heart disease, so it's obviously a right to left shunt, a very high hemoglobin and an extremely high PCV. Remember, when you have gross erythrocytosis because of hypoxia or any other condition, your rule of 3, hemoglobin multiplied by 3 PCV should be the PCV, does not usually match because of the number of RBCs is increased so much. And we, like you said, both PT and aPTT are prolonged. And the consultant thought because he has blood tinge expectoration, both PT and aPTT prolonged, let's give FFP, that will cover both. So the problem in this case is actually, so I did not give you one value purposely. So why is the hemoglobin high? Because rightly you pointed out that there is secondary erythrocytosis. So really leading to polycythemia. So that's why the hemoglobin is high, and so is the PCV. Now, what has happened in this case? So another lab hematologist now calls for another sample in what is called a citrate adjusted tube in view of the CBC. So what in the CBC told this hematologist to ask for another sample in a modified tube. Let's go back. It is these two values. And more importantly, I'm now concerned with this. And remember, this is resultant from a high RBC count only. Only then the PCV can be so high. So what has happened? So in the citrate adjusted tube, the second tube now, their values are absolutely normal. So from complete derangement there, PT, aPTT, we are now to completely normal values. So what has happened? Let's look at the next slide coming up. So in this case, actually then the FFP transfusion was not required. And you could attribute the hemoptysis due to pulmonary congestion. So remember, if it's a hypoxia, your lungs will be congested, capillaries are congested, pressures are increased. Some of them can rupture and cause hemoptysis. Although I built up this case so that it will lead to the diagnosis that you made. But still, some important points to consider. So whenever you look at a high PCV and you get abnormal coagulation results, there is something else to look at. So let's go to the next slide. So let's say this is a normal sample, not our patient, normal sample of coagulation received in the lab. You spin it and you find a column of red cells and you see plasma, right? Now the blue I put in is actually within the plasma. This is anticoagulant, which is already in the tube. I just put it in a different color to show you the amount, approximate amount. So in this tube of PT or aPTT, a citrate tube blue cap, when we spin the sample, this is what we get. And like I said, on a visual examination, you will not see blue because the anticoagulant is mixed with the plasma. So that's what happens in a normal situation. That's your red cell column, plasma. In our patient, what has happened? His PCV is very high. So his red cell column is much higher than a normal patient's here. And because of the total volume taken is always same, either 2 ml or 3 ml or 4.5 ml in the citrate tube. So your amount of plasma in this case is less because the red cell column is much higher. But if we use the same tube, we gave this patient the same amount of anticoagulant. So that is why the anticoagulant was in excess for this plasma and the PT, aPTT were spuriously or artifactually prolonged. They were not actually prolonged. So if you do a citrate correction, which means I'll show you the next one. So after adjustment, what do? You look at the red cell column is still high, plasma is less, but what have we done now? We've reduced the amount of anticoagulant. There's a calculation I'll show you in the next slides. So for this plasma, compared to the normal plasma, this does not need the whole amount of anticoagulant. This needs less. So we did this repeat sampling in this tube, which has less anticoagulants, and your test came back to normal. So this is called citrate or anticoagulant adjustment. You must consider this whenever you're looking at a patient who has polycythemia and coagulation results are deranged. So also look at whenever your hematocrit is more than 55%, you need to look at this carefully and do this correction. Less than that, even if there is a hematocrit, say 53, 52, it will not matter too much clinically. But beyond 55, a citrate correction must be done. The reverse, if your patient is anemic, he is likely to have a low red cell column, more plasma. So do we give it more anticoagulant? No. So correction for anemia, I think 2008 paper is not required. But for hematocrit, which is high, you require a correction. There are formulas, two formulas given, different sources. Whatever the formula, you can actually calculate and keep it once in your lab. So let's say I'm using a 2.7 ml container, and this calculation or this figure goes in here and here if I use the other formula. So whenever you look at this, your hematocrit, let's say your hematocrit ranges from 67 to 79, too high, but still, and then you calculate from the formula and you can make a table and keep it in the lab. So what does this mean? In our patient, the hematocrit was 70, 70. And if we were using a 2.7 ml container, we would need to take out the 2.7 ml container has 300 microliters of anticoagulant, sodium citrate. So if our hematocrit is 70, we need to take out 150 microliter of anticoagulant, discard it. So 150 is left in the tube now, and in this tube, the repeat sample is taken. So what have we done? We've reduced the amount of anticoagulant to compensate for the less amount of plasma in this patient. So am I clear, Preeti and others?
Yes, sir. Yes, sir.
Okay. So this will be given in books as one of the pre-analytical variables, but not often practiced. So if you start doing it, you'll find changes. So the final impression in this case was secondary polycythemia requiring citrate correction. The tests were artifactually prolonged. Go on to case 2, Dr. Gifty. Can you discuss this?
So it's a clinical history of an 8-year-old boy with spontaneous swelling and bleeding, sir. So with looking at the lab values, he's having just a mild anemia, but his aPTT is isolatedly prolonged, sir. So if I take that he's a male child who's having a recurrent episodes of bleeding with an isolated aPTT increase, sir, I mostly prefer to say it's a hemophilia A or factor 8 deficiency, sir. If I put all the clinical history together, I more prefer this diagnosis, sir.
Right. Two questions for you. One, what if I did not give you the CBC and PTA, PTT at all? What would you think from the history alone?
You mean without the PT and aPTT values, sir?
Even the CBC. HB onwards till aPTT, I did not give you. What will you think from the
Okay,
history
sir.
alone? The first 5 lines.
So with recurrent episodes of bleeding and on and off for 3 years, sir, I would just think first generally a coagulation disorder, a very broad term. Then I would
Yes. Then
then I would request the aPTT and PT and CBC to be
no,
able to.
I'm asking you still on the history and clinical details.
Okay, sir.
So when you say you would think of a coagulation disorder, you're absolutely right. Which one?
The coagulation disorder specifically, sir, hemophilia, sir, because of the young age, actually.
Right. So I asked you this question because, like I said, if I did not give you any investigation from that history, which is so classical,
Yes,
you will still think of hemophilia. Unless
hemophilia,
you
yes,
get it,
sir.
right?
Yes, sir.
My second question, there is no significant family history. We know that hemophilia is inherited. How would you explain?
Yes, sir. So it's an X-linked disorder, sir. So I read it about the carriers does not necessarily need to give it to the next generation, so it can be skipped.
No,
So
but what
I'm not.
about if you
Yes,
go back on the maternal side, you would usually have a bleeder history.
yes, sir.
So that is not there.
So carriers usually don't show that
Carriers
clinical
not.
feature.
But you in the family history, what I mean is there will be a hemophilia male somewhere up
Yes, sir.
in the
Yes, sir.
family. Even that is not there. So how do you explain that?
I'm not sure, sir.
Males will not be carriers, no? Females will be
Yes, sir.
carriers.
Yes, sir. Yes, sir. I'm
Okay, so
not sure, sir.
doesn't matter. So we'll address this as we go along. So let's discuss this case. Again, I've highlighted important points. So it's a boy, swelling left knee off, on and off, since 3 years of age. This age is important also. You could have this probably since 2 years of age or so, because till that time they are cuddled by the mother, kept in the cot, kept very safe. It's about 2 to 3 years, the toddler time, when they start running around on their own on their knees, bang their head here, hit their knee, and they start bleeding. So that's important. So the spontaneous swelling in the left knee is usually a bleed. Nothing else explains this. So a recurrent knee swelling in a boy, think of hemophilia. Knee is the commonest site of bleed, also called the target joint. And the target joint is a joint that bleeds much more common than the other ones. Knee is the commonest target joint. So the knee is tender because it's an acute bleed now with restricted movement during episodes. So as the bleeds increase, the bleeding is, remember, is inflammation still. It's a chemical inflammation. There is no infection. So each time the inflammation occurs, the repair occurs by a bit of fibrosis restriction. So gradually they develop deformities. So by 8 years, you will not have too much deformities. But if it grows without appropriate treatment to say about 15, 20 or more years, you will have a significant knee deformity. So you have a spontaneous swelling, so spontaneous bleed, and also falling trauma while playing. There is no significant, so no significant family history. 1/3 of the patients can have a spontaneous mutation, somatic one. So you may not have a family history in 1/3 of the patients. So don't worry about that. So like you said, the CBC is more or less normal. PT is normal. So which pathway is normal when PT is normal?
The extrinsic pathway is normal, sir.
Intrinsic pathway, excellent. And the aPTT is abnormal. So which pathway?
The intrinsic pathway is been affected here, sir.
So we know which 4 factors are involved in the intrinsic pathway.
Yes, sir. The 11, 9, 8, and 10,
12.
sir.
12.
12, sorry, sir. 12,
10.
12, 11, 9, and 8, sir.
Yes, right. So from this history alone, if I was not given any investigation, I am already thinking of hemophilia. And in your answer, I believe you said hemophilia A. How
Yes,
did
sir.
you reach hemophilia A? Why not B?
So, if because of the male child, sir,
No?
X-linked. Yes, sir.
Hemophilia B is also X-linked, same
Yes.
inheritance.
Sir, it's more common to have hemophilia A, sir. So
Yeah, but one should not assume. Although
yes, sir.
80% will be hemophilia A, 20% B. But if you assume and treat based on that, what if you were wrong?
Yes,
So
sir.
your diagnosis here should be a hemophilia likely, considering
Okay, sir.
a prolonged aPTT, which is isolated and everything else is normal. Male
Yes,
child,
sir.
hemophilia. That's it.
Okay, sir.
Okay, so now what do we do? So we go back to the pathway just for a confirmation. So if we saw the PT was normal, which means this pathway 7, 10, 5, and 2, and even going on to 13 would be normal. Only then the PT can be normal. So which means the problem lies here, these 4 factors. And with that history, we are thinking of either 9 or 8 deficiency, which is hemophilia. You are very right in thinking that way. So let's consider some things. The history is diagnostic in hemophilia, like we just saw. I said those 2-3 lines of history initially was enough to say possibly a hemophilia. And like I gave you that history, there was no family history, so all patients may not have a positive family history. One of the important points by which hemophilia is missed in India and many developing countries is that a lot of centers do an PT, but not an aPTT. And it's some of the centers think, how is this possible? It is very common in India. Lots of lab doing either no coagulation at all or only a PT. If you do not do an aPTT, you're going to miss all hemophilia patients. And then your lab diagnosis, I will show you in the next few slides, should always follow a stepwise approach. That will teach you a lot and will save a lot of money for the patient. So in case of an atypical bleeding history, rule out 1 milligram disease. So this patient had a tissue joint bleed, a deep tissue bleed. If you have an atypical bleeding history like say mucocutaneous or platelet like alongside, then you must rule out a 1 milligram disease as well. So have any of the students heard about mixing or correction studies?
Yes, sir.
Okay. So can you give me a basic idea so that I know where to start and how detailed to go? Basic idea of a mixing study.
So it is actually a mixture of 1:1 ratio of the patient's plasma along with the normal plasma, sir. We
Right.
want to see, so after it's done after a PT and aPTT is done. So we need to classify now exactly where the patient lies in the coagulation problem, whether it's an intrinsic or an extrinsic pathway, sir. So
Right.
if it does get corrected after mixing, then we can suggest that it is a coagulation factor issue, sir. So if
Right.
it is still prolonged after that, then we can suspect maybe some other inhibitor is
Right.
causing the issue.
Excellent. And what if we now know that it was corrected and it's a factor deficiency? So then what?
Then we can do a specific factor assay after that. So like 8 and then 9, and then we can confirm if they
How
belong.
will you know which one to do, 8 or 9?
I'm not sure, sir.
Okay. So let's start with that. Your first point on the mixing study is right on dot, very correct.
Yeah.
So the basis of mixing studies of 2-3 types. The basis is the patient or the test plasma is deficient in a factor or factors. Usually when we deal with hemophilia, it's obviously one factor. The normal or the control plasma has all the factors. So if you take your own blood or I take my own blood, we will have all the factors. While the patient who has hemophilia is either 8 is missing or 9 is missing. So that's the basis to start with. And like you said, when we mix, so it's almost like a rich plasma versus a poor plasma. So the poor plasma lacks some factors that the rich plasma is able to give. So when the rich plasma gives money to the poor or the factors, the poor becomes at least a moderately rich person. So that's the basis of a mixing study. So spot the difference, easy. What's the difference between the two?
The
Yeah.
green circle is missing,
Yeah.
sir.
So this
and
one
the
is not
smiley
there.
face.
So I just drew this cartoon to illustrate. So let's say this is a normal sample or control plasma. This is your test patient. He has one factor missing. We don't know which one, but one factor missing, and the control has all the factors. So when we mix the two, the control, which has excess of all factors, actually supplies the missing factor to the test patient. So the aPTT comes back to normal. So if this happens, which is the basis of a mixing study, you know there is a factor deficiency. So which means mix your test patient with control plasma equal amount, 0.1 ml, 0.1 ml, do an aPTT again. If it was 110 in our case, it will actually jump back to 28, 30 or so. That means a typical correction. And that tells us there is a factor deficiency. Next question is, so before we go on, if there was no correction, we rightly said either it's a lupus anticoagulant or an inhibitor. Then you go on a different path. But our case is with correction. So next question now is which one? So like you said, let's do factor assays. If you do an 8 first, it turns out to be 9. 2,000 to 3,000 rupees are wasted. So we must focus on or quickly on which factor. So there are two methods for that. I'll just give you one. And the importance is, if you give a patient FFP, suppose I do not want to know which factor. I just say broad hemophilia. But I give FFP. FFP has fractional plasma has all the factors. It has 8, 9, 10, 5, 2, everything. So it will supply whatever the missing factor was. You don't even know the diagnosis. But if you're giving specific factors, as is the norm now, we avoid plasma for the risk of infections and other things and volume overload. So if you give specific factors like 8 or 9, then I need to know specifically which factor. So olden times, a lot of hemophilia patients were on FFP therapy without knowing which factor. So now it is important to decide which factor is deficient and then treat accordingly. So mixing studies, I'll give you 3 steps. The first step we've already explained, mix with control plasma. If your aPTT comes back to normal, it's a factor deficiency. I'll just give you, I will skip the third step, but I'll give you the adsorbed plasma and aged serum because these are easy done in the lab and you can actually work it out yourself. So the basis is adsorbed plasma because of a chemical treatment with aluminum hydroxide or barium sulfate. We mix it with normal plasma, spin it, incubate it, and then the adsorbed plasma, the barium sulfate or the aluminum hydroxide adsorbs or gets some factor stuck onto it. So in the free plasma, only factor 5, 8, 11, and 12 are left. So from all the other factors are adsorbed onto the chemical, and the plasma which is adsorbed now has only 5, 8, 11, and 12. Age serum, very easy. Go to your biochemistry lab, tell them I need a serum sample which is 48 hours old. Ideally, 3 are required. You can test with 1 to begin with. So you can just take an age serum, and this has in this the labile factor which is 5, 8 would have been lost. So this serum has 2, 7, 9, 10, 11, and 12. So what have we done? We've created 2 sets of serum here and plasma there, which have 4 and 2 different factors, but 2 common factors. If you notice, 11, 12 are still there, 11, 12 are still there. Now, instead of mixing with control plasma, we mix with adsorbed plasma first. We have to do these both. You can't get away with one. And then you mix the patient plasma with age serum. So if the patient is deficient in factor 8, what will happen if you correct with adsorbed plasma? Will the aPTT come back to normal or no?
It will come back to normal, sir.
Yes, because this can supply the factor 8.
Yes.
And we are looking at hemophilia, so we're looking at either 8 or 9, right? So if it does not correct with adsorbed plasma but corrects with age serum, then factor 9 would be deficient. If your patient has 11 or 12 deficiency, it will correct with both, obviously. Why are we not talking about 10 and 2 and 5? I'm not talking about 7, 5, 2 and 10 here.
So 7 is intrinsic pathway, sir.
7 is extrinsic pathway. I'm not talking about those still. Why? Even in the correction. Because remember, in our case, PT was normal.
aPTT, yes, sir.
Right? Our PT was normal, which meant that 7, 10, 5, 2 had to be normal. So I'm not worried about those. If it's hemophilia, I'm looking at does adsorbed correct it, which will mean factor 8, or does aged serum correct it, which will be factor 9. Right? So DACY will give you this table for corrections, whichever factor. So let's look at factor 8 deficiency first. Our aPTT of the patient will be abnormal. Aged serum, there is no correction. Adsorbed plasma, there is correction because adsorbed plasma can supply 8. And obviously with controlled plasma, there was correction. With 9, turns opposite. No correction with adsorbed plasma. Corrects with aged serum, which has factor 9. 11, 12, remember, aPTT was abnormal. But if it is 11 or 12 deficiency, it will correct with everything because they have everything. If it is inhibitor, obviously, no correction. So am I clear with the mixing studies?
Yes, sir.
Okay. And then, depending on which factor, suppose I found, okay, factor 8 was deficient in this case. Then I put up a factor assay. That's not the premise of this talk, but you can on the graph, and this one actually is not cutting the control line, standard line. So this will be less than 1% of severe hemophilia. So I'll give you another example on a basic workup. So in this case, CBC was normal. Typical bleeding history. Bleeding time was normal. So this tells me there is no platelet problem. So we are on the coagulation area. PT of the test is 12. Control is 14.8. Fine. aPTT is prolonged. Control is 30. PT is normal. So I'll take you through the mixing study steps. The first step is half patient and half control aPTT comes back to normal from 56.8. So it tells me there's a factor deficiency. I do a mixing now with adsorbed plasma. It corrects. So I'm thinking of 8 deficiency. With aged serum does not correct, so it has to be factor 8 deficiency. We put up a factor 8 assay. That was 1.5%, so that's moderate hemophilia. Factor 9 assay, if you have to do, although not required now, was normal. So the final impression in this case was severe hemophilia A. Shall we move ahead or are there any queries? Shall we move ahead?
No questions, sir.
Okay, right. So case 3, Dr. Dhaval. Can you run us through this case?
Sir, 65-year-old woman with worsening pneumonia, and she is febrile, and urine output is also dropped, and the blood tinged and she aspirated around the central line, and there is also total leukocyte count is also increased, platelet count is decreased, PT, aPTT, and Thrombin time is also increased. It's look like sepsis-induced DIC, sir.
Right, excellent. So this is a classical background of sepsis-induced DIC. Remember, if you start looking at factor deficiency and you say PT is prolonged, so 7 may be deficient, aPTT is prolonged, so 8 or 9 or 10. So you're looking at actually multiple factor deficiency. So this you can't pinpoint to one factor. Obviously, some will be depleted faster, but you're looking at multiple factor deficiency. And in this background with thrombocytopenia, your usual answer is CBC. DIC. So in your hospitals, your ICUs, DIC would be extremely common. Your mortality rates 40 to 60% once the patient goes into DIC. Sepsis is a common one in hospital practice. So let's discuss this case. So you have a pneumonia on ventilator. So this seems like infection. If you'll just look at this now, febrile, but then urine output dropping, blood tinge so looks like multi-organ failure developing. So bleeding from multiple sides, upper GI and the central line. So that's again typical of DIC. Hemoglobin is not that bad, not that dropped, but your everything else is prolonged. Platelets have dropped. PT, TT, and aPTT are prolonged because of multiple factor deficiency because of DIC. What's the full form of DIC? Anybody? The full form of DIC, anybody?
disseminated intravascular coagulation.
But what is happening to our patient?
Uh,
Is she coagulating or is she bleeding?
so she's bleeding.
So how do you explain that?
So platelets are also decreased, sir. There's thrombocytopenia, 20,000. And so PT is prolonged.
No,
aPTT is
that
also
I
prolonged.
agree. That I agree. But the disease is called coagulopathy. How come
Yes.
bleeding is happening? Okay, so this has the DIC has two phases. You have the coagulation phase where thrombosis occurs, especially microvascular in vital organs, and then you have the bleeding phase. So in the coagulation phase, some trigger, which is infection and the endotoxins here in this case, that triggers coagulation. So when coagulation is triggered, especially in the small vessels, what is happening? To make those thrombi, microthrombi all over your body, small organs, the small vessels and major organs, you consume platelets, you consume factors. So that is the phase of coagulopathy. Once they are consumed, you don't have anything to function. So then the patient bleeds. So actually, if you've picked up this patient in the bleeding phase, you've lost the bus. So if the patient was developing sepsis, TLC rate going up, urine output dropping, that is the time you should start thinking DIC is developing already and start serially investigating. So this patient actually has been caught in a late stage when the bleeding phase is occurring, and that's why the mortality is very high. So a term that I often teach my residents is death is coming. You should actually look at DIC also as death is coming because of the high mortality and the severe problems and the morbidity that the patient lands up with. So it's a serious disease. So if you have a DIC coming up, mortality is very high. So which further test would you do now that you're thinking of DIC? I've given you a lot of CBC and coagulation test. Which other test would you do to confirm your diagnosis?
Hybridization, FDP, D-dimer.
D-dimer levels.
D-dimer. Anything else? Anything basic? Obviously, D-dimer, I totally agree. That's your confirmatory test in a way in this background. Any other test?
So peripheral smear.
What would you see in the peripheral smear? Excellent.
So cystocytes can be seen, sir.
Why do you see cystocytes?
So it's a case of like hemolysis will be there, sir, and
DIC is not hemolysis. That's a
uh,
misconception. Okay, let's
so
go ahead.
angiopathy, microangiopathy is there.
So what will happen? Okay, so presence of schistocytes in the presence of thrombus. There's only one platelet in this field. This is typical of DIC. Remember, this is seen in many other conditions, PTP, HUS, but in this patient's background, which is screaming at you that this is DIC, you will say schistocytes. How are they formed? So imagine a very small vessel and which has thrombosed fresh, and there are some RBCs wanting to go through it. So as they come through the vessel, the fibrin in the clot is very sharp. It actually tears and injures the RBC. So if you see this means this RBC has come from a vessel which has been thrombosed, partly thrombosed, and it has struggled through coming out in the peripheral circulation and has got injured by the fibrin, and that is indirect evidence of presence of a thrombi. That's why schistocytes are there. This is not typical hemolysis. And you would
Okay.
obviously do a D-dimer because it's a cross-linked protein dimer, the D-dimer. Some misconceptions about DIC. One, the DIC means bleeding, like we saw in our case. Remember, clinically late stage, yes, bleeding, but it starts with coagulopathy. That's why the name. And also that D-dimer positive means DIC. This is the commonest misconception. D-dimer can be positive in deep thrombosis, pulmonary embolism, post-operative, and cautery is used to thrombose vessels to stop the bleeding, multiple trauma, pregnancy. So a D-dimer positive only in the background of such a case or where DIC is likely to happen is positive for DIC. A D-dimer positive just tells you there is thrombosis going on somewhere in the body and it is picking up the breakdown product. A word about sensitivity and specificity of D-dimer. If you have thrombosis in the body, D-dimer is very sensitive to pick it up. Specificity. So let's look at DIC as a disease. If D-dimer is positive, it does not always mean DIC. So it is not very specific. It could be post-operative trauma or other conditions like I mentioned. But sensitivity is very high. And so is the negative predictive value, which means if you were thinking of DIC, if you were thinking of pulmonary embolism or thinking of DVT, and your D-dimer is negative, then you are almost 99% sure that disease is not there. So that is why when it has a very high sensitivity for DIC, it also has a very high negative predictive value. Very important. Another misconception is that you will always have PT, aPTT derange in DIC. Does not always happen. Even especially in the initial stage when eager clotting is happening, PT and aPTT might even be short, a little bit shorter than normal. It's only late stage that they get prolonged when all the factors are consumed. And I already mentioned about the utility of D-dimer in DIC. So if your patient seems to have DIC and the D-dimer is positive, then it supports your diagnosis. But if your patient came walking with something else and he is showing you a venous thrombosis on the superficial veins and D-dimer is positive, it is not DIC. The D-dimer is positive because somewhere else, maybe a small thrombus is breaking and giving you the D-dimer positive. Another condition, the fibrinogen must be low in DIC because remember we said we consume all the factors. So in the factors we also require fibrin. Fibrin comes from fibrinogen. Now imagine our patient who had sepsis. Okay, I'll ask you a question. What is common between ESR, CRP, fibrinogen, and serum ferritin?
So they are acute phase reactants.
Very good, very good. So fibrinogen also is an acute phase reactant. So let's imagine our patients, the normal fibrinogen is about 180 to 400 or 350 milligram per deciliter. So let's assume our patient's initial fibrinogen was 250. He went into sepsis, fibrinogen rose to 800, right? Acute phase reactant. He goes into DIC, fibrin is now consumed, fibrinogen falls, but it falls to say about 200, still within the normal range. So he's actually going into DIC, but fibrinogen normal because of the acute phase reactant. So sometimes fibrinogen alone may confuse you. And also that one test panel or one report is enough. If you're thinking of DIC, you should do serial testing, maybe even morning, evening if your patient is destabilizing fast, but at least a daily monitoring of parameters, CBC, PT, aPTT, D-dimer. And then you will be able to catch this patient early and initiate treatment. So the final impression in this case was disseminated intravascular coagulation. Case 4, Dr. Shubda. Dr. Shubda, are you there? Okay, no response. Dr. Sharayu? Dr. Sharayu, can you discuss this case? Okay, Dr. Dikesh? I'm not able to see you from the screen. Are you there? Dr. Sharayu, Dr. Dikesh, Dr. Shubda? Okay, maybe connectivity problems. I'll go back to Dr. Preeti. Dr. Preeti, can you pick up this case 4?
Yes, sir. 50-year-old male, sir, resolving pneumonia. Patient is stable now, no bleeding from any side. Sir, according to the labs, we can see the the PT is prolonged, and sir, the aPTT is also prolonged, sir. And
Right.
so the patient is not having any bleeding currently.
Right.
So as it is a resolving pneumonia, so I think maybe the patient is having a lot of course of antibiotics. So sir, it can be like it can be a vitamin deficiency. So in that case, sir, it can be a vitamin K deficiency, sir, because there's reduction in the vitamins and the gut flora also, sir.
Okay, that's a long shot because okay, let me just give you let's say this patient has only 7 to 10 days history of antibiotics. Not a very long history for vitamin K deficiency to develop.
Okay, sir.
So I've taken that out of the equation. Okay, I'll give you a clue. There is something
Yes.
in the right lung field that can help you. The right lung field.
So NG.
Something
Cent-
else? NGT would be more central.
That yes. So
There. So this is a
it's a
central line.
central line. Yes, sir.
Right. So now can you think of the answer to this case? Okay, doesn't matter. We'll go along.
It's a heparin.
Yes, very good. It's very good. So resolving pneumonia, stable patient, CBC not too bad, PT, aPTT prolonged, platelets normal. So right lung field I just pointed out, you picked up a central line.
Yes.
So the sample was taken from the central line, and we know that central line to take care of their patency are heparinized most of the time.
Yes.
And adequate precautions were not taken, so the sample was contaminated by heparin. Heparin throws aPTT through the roof, also affects PT. And if you're suspecting heparin, do a TT. TT is markedly prolonged when there is heparin contamination. So this is a typical pre-analytical problem, not very uncommon, happens in ICUs, recoveries, post-op patients, where care is not given to coagulation samples taken from the central line. So in this case, although the tests were prolonged, the clinician would not act because there is nothing, no bleeding. So why would you treat? So important, treat the patient and not the test. So actually the clinician should have called up and maybe called up, I don't know this scenario, called up the lab to say why are these abnormal when we are getting, and usually the lab hematologist will ask for where was the sample taken and so on, and then you'll sort out the problem. So line samples are notorious for dilution and heparin contamination and resultant artifactual coagulation results, as in this case. So what you must do is do a 5 ml saline flush, 5 ml discard volume, and then take a sample. However, the best is a poked sample from a vein for coagulation. Avoid line samples for coagulation testing unless really pressed for it, because you can have very wrong results and treatment in these critical scenarios varies. So a final impression in this case was heparin contamination causing artifactual results. Case 5. Let's go back to Dr. Shubda, Dr. Sharayu, Dr. Dikesh. Anyone available? Okay, Dr. Gifty comes back to you.
So this is a 17-year-old girl with a clinical history of heavy menstrual bleeding. Also has a past history of frequent bleeding, sir, and it also has a positive family history. In the investigations, when I look, she's having a microcytic hypochromic picture, sir.
Right.
And she's having a very low ferritin value, which points out that she might be having an iron deficiency. But when I look at the coagulation profile, her bleeding time is increased, but her PT is normal, but her aPTT is prolonged, sir. So if I look at the bleeding time, it gives me an idea that it might be a primary hemostasis issue. And the aPTT, so if I look back and study, actually, because the bleeding time is increased, it can be a primary hemostasis, which mostly points to a von Willebrand factor deficiency. And the aPTT supports my case because von Willebrand factor also acts as a carrier for factor 8.
Right.
So hence, it might explain why aPTT also is increased. So
very good, very correct diagnosis. So let's look at the pointers in this case. So one, we are not dealing with the boy, so hemophilia seems to be out. Heavy menstrual bleeding, since menarche, past history, mixed bleeding. So mucocutaneous, tooth, easy bruising, skin, and then a deep tissue bleed. So she has a platelet type bleed and a coagulation type bleed. So a mixed bleed is typical in von Willebrand. Similar bleed in the mother. So you have a inheritance basis, ecchymosis presently, but also had a history of tissue bleeds. Investigation, like you rightly picked up. So the iron deficiency here is because of these repeated bleeds, chronic blood loss. One bleed, two bleeds will not cause iron deficiency, but she's been bleeding off and on. So that causes the iron deficiency, unrelated to the coagulation disorders directly, but an outcome of bleeding. So bleeding time is 13 minutes. Your platelet count was normal. So this means there is a functional problem with the platelets. PT is normal, so extrinsic pathway is fine. aPTT abnormal, so factor 8 likely in this combination. So this is a typical history of a von Willebrand disease with, remember, factor 8 in some of the variants may not be low. So the factor 8, the aPTT may be normal in some of the variants. However, this history of, and also remember, von Willebrand disease is the commonest inherited coagulation disorder in the world. 1% of the population has von Willebrand disease. Because most of it is mild, they present either do not present at all, or when some insult is there, like menarche, following menarche and menstruation. So the OB/GYN clinics where menorrhagia is very common is a good area to pick up von Willebrand, which goes undiagnosed at times. So very correct diagnosis. So consideration, we had an inheritant basis. It was autosomal, not in males, mostly mucocutaneous. There was one tissue bleed, so a mixed pattern of bleeding. And the CBC ferritin pointed to iron deficiency because of a significant bleeding history. You had normal platelet count with mucocutaneous bleed, so a functional problem there. Hence, a prolonged bleeding time and a prolonged aPTT. So very well done. So von Willebrand disease. Case 6. Dr. Dhaval, are you there? Doctor?
45
Yeah,
male
please.
with excessive bleeding after tooth extraction, and workup for initial, there is a decrease in factor 8, and
Right.
diagnosis initial diagnosis is mild hemophilia A, and after the blood stop and there is no FFP given, it is rule out the absence of factor deficiency, and there is a normal of PT and aPTT. It also rule out the absence of the factor deficiency, and with repeat testing, the factor 8 is also normal. And it looks like a pre-analytic error.
Right. What do you think is the possibility? Okay, it doesn't matter because from this history you can't think of what is going on, but you're very right on that. This seems like a pre-analytical problem because if your factor rate was low at one time, inherited, that cannot come back to normal because nothing was given. So obviously there's a problem with that sample. So let's look at what happened. So bleeding following tooth extraction is a typical history for mild hemophilia. They sometimes, when they have a hemostatic insult, they present for the first time. So dentists are also taught that this hemophilia may appear on their table, on their chairs, dental chairs. So sample sent was factor VIII assay. What if a PT and aPTT were sent? Anyway, factor 10 was low. Diagnosis was this. Bleeding stops with local measures. So if it was hemophilia bleeding away, it won't stop usually with local measures. So you require factors or FFP support usually. And why did the factor come back normal? So what had happened? There was a clot in the first sample. So I wanted to look at this sample only. I'll talk about this later. So there was a clot in the sample that was picked up by the resident, thrown, and the sample was sent to the lab still. So this happens very commonly when hard-pressed, time-pressed residents do this. This can cost the patient a lot of money and a lot of erroneous testing and diagnosis. So what happens if there is a clot, even if a small one, that has consumed some RBCs, some platelets, and coagulation factors in formation of the clot. So the remaining blood and plasma are depleted of the factors. So that is why that factor assay came abnormal. And on a repeat sample, when there was no clot, everything was normal. So the problem in this case was a pre-analytical error because of a partially clotted sample that was erroneously tested. Now, this is another scenario where sometimes if you talk to your clinical colleagues, sometimes they will ask you, why do you reject samples once you accept them? So this happens quite often in coagulation. So this is a PT sample received. It has been spun now. The blood column is below in here, and you can see the plasma. What you see is wisps of small clotted material. So these are microclots or small clots. These also consume some factors. How much we can't predict. But if you see, and you will see these only after centrifugation, not when the blood is like this. So sometimes after centrifugation, your technician might show you, so there are microclots, what do we do? This sample goes for a rejection straight away. There is no point testing this. You can have erroneous results. So remember, in this state, you would have accepted the sample, not with the clot, obviously. But once you spin, if you find a clot, you have to call the resident on the clinical side and tell them you need a repeat sample. So in our case, the first sample tube had a small clot that was thrown out. So important, a stepwise approach is always right. If PT and aPTT were done initially, hemophilia would not have been suspected. When things don't add up, as in this case, there will always be an answer, which was the pre-analytical problem in this case. And we mentioned about sample integrity. And another practice that as residents and faculty in pathology, everybody must do is do not return the bad or the rejected sample. The human mind is amazing. It can actually, if you say this is clotted, the sample goes back to the ward, the resident picks up the clot, throws it in the dustbin, and sends a repeat sample, and you get all haywire results. So keep the bad sample or the rejected sample in the lab and do not reject that. Do not send it back to the clinical site. So the final impression, a pre-analytical issue, partially clotted sample. So the last case, let's look at Dr. Shubda, Dr. Sharayu, Dr. Dikesh. Are you there? Any of you? Okay, we go back to the star of the day, Dr. Preeti.
Yes, sir. So, 7-year-old girl has ecchymotic spots off and on over the body for 4 years. Now presents with a hematoma in the left thigh. She also has a history of prolonged umbilical stump bleeding. Her wounds also do not heal well. In the lab, sir, we see the PT is almost normal, sir. The aPTT is almost normal, and sir, the TT is also normal. The thrombin time.
Right.
Sir, according to the history, sir, we can see prolonged umbilical stump bleeding. Sir, we can suspect factor 13 deficiency, sir.
Very good. Very good. So this was an actual case many years back when we were starting our coagulation lab, specialized lab initially. We got the same results and we reported this as no bleeding disorder. But the clinician was assistant. He said, this looks like an inherited disorder. The bleeding history is like that, bleeding for 4 years. So that is the first time we set up the test for factor 13 deficiency, which was the factor 13 screen, also called the urea clot lysis test. So we observe it on day 0 when we set it up and observe after 24 hours. So what happens? We take 5 molar urea solution and then we make a clot. How do we make a clot? Take plasma and either add thrombin or add just calcium. So your citrated plasma take from the patient and control, and from that point 500 microliter of the plasma just add calcium or thrombin and it will form a clot immediately. You suspend this clot in 5 ml of 5 molar urea solution and leave it. And after 24 hours, what we saw was in the control tube, the clot was still there. In the test, the clot had disappeared. So remember, what is another name of factor 13? It is fibrin stabilizing factor.
Fibrin stabilizing factor, yes, sir.
So if you notice here, once a clot is formed, it has to stabilize by factor 13. So if it is 13 is not there, it will deteriorate with the bonds that the urea breaks it further. So this was factor 13 deficiency, and this test is crude but works in only severe deficiency. Mild deficiencies, you need a factor 13 assay. So the message from this slide was we may need to look beyond the pathway. So if you look here, in this, your intrinsic pathway, extrinsic pathway, common pathway, everything is normal. So factor 13 is beyond this once the clot has been formed. So you will see normal clot and you think why would this be a clotting disorder? But the clot does not stay for long. That is why that prolonged umbilical stump bleeding and the wounds that do not heal well. Okay, so that was factor 13 deficiency. Thank you. I hope I've not complicated matters for you more. Any queries, I'll be happy to answer.
So there are some questions in the chat box.
Yes, please.
So Dr. Kushi wants to ask, will hemophilia C deficiency, that is hemophilia C 11 deficiency, respond to both adsorbed plasma and HCl?
Yes, because factor 11 is present in both of them. So if it is a factor 11 deficiency, your prolonged aPTT will correct with H serum also and adsorbed plasma also. And if you're looking at 11 or 12, then remember 12 deficiency does not have a bleeding history at all. Patients with 12 deficiency, however severe, do not bleed.
So there's one more question from Dr. Neeru Singhal. She has asked to explain the graph slide in case number 2.
I've stopped sharing and go back. Okay. I said this was not the premise, but still, if you're interested, I'll let you know. So this is a semi-log paper for factor assays. Nowadays, you use a lot of automation, so a lot of people do not depend on these, but it's good to learn this. This helps a lot. So if you notice, the gradations are not similar, right? So this is a semi-log paper. The normal kinetics of coagulation is curvilinear. So you'll go have like this. So the normal plots of, if you plot normal times of clotting, they are like this. So on a semi-log paper, the times are converted to straight line for easy to assess. So that is why we use what is called a semi-log paper. This you can actually download from the internet also. It's freely available. Your local stationery may not have this that commonly. And then you pick up the, so this is on this axis, you have times. You have the times in seconds. That is your, not the aPTT now, your factor assays. Remember this for the factor assays. So what we do is, from a test plasma, we use factor deficient plasma and can prepare a dilution, a 1 in 10 dilution with buffer of your test plasma, and arbitrarily assign it a value of 100%. So a test plasma diluted with buffer and assign it as, in a 1 into 10 dilution, you assign it as a 100% value. And then you dilute this tube half. So if you had 500 microliter, add 500 ml of microliter of buffer. That makes it 1/20. To another tube, use half of this and half of 500 microliter of buffer again, and that reduces it down to half again. So on this axis now I have arbitrarily assigned factor level of 100%, 50%, and 25%. Then this is your control line. So you set up dilutions of test plasma from where you got the times. So you test and control the standard and the test plasma. You set up dilutions, these dilutions, and then do their plotting time using the aPTT reagent. So if you do an aPTT reagent, what do you need? You need plasma, calcium, the aPTT reagent. In this reaction mixture, you also add factor 8 deficient plasma if you're doing factor 8 assay, or factor 9 deficient plasma if you're doing a 9 assay. So then obviously as you dilute, your time will be prolonged. So let's say your standard first point was say 46, the next point is 54 something, the next point is 62. You draw a straight line. This is your control line. Now your test is deficient in some factors. So when you do the test times, it starts here. So remember our case was about 110. So your first point on the test is here, second point is here, and that also goes for the straight line. To do a factor assay or estimate a factor assay from this, what you do is take a point on the 1 in 10 dilution, assuming it to be 100%, take a point beginning from there, take it across to the standard line. So it is not cutting, which means it goes less than 1%. So remember, if you said 25% here, that's 2 and 3, assume this as 20 to 30. So 25, then it becomes 10, and then single digit, because semi-log 98761 is a 1 here. So this line is not cutting it, so it's less than 1%. If my point started here and it dragged on to the control line here and cut it down somewhere here, you will get it 2%. So same way, you can actually plot the, so if this point was here on the test, it will cross the line of control here and give you a factor level of say 7-8%. That's how you interpret. You can look at DAISY and online sources for further details. Any other queries?
So there's one more question. If plasma serum color red, can I do any value difference in the sample as red color?
Yeah, so the color one will create a problem if you're going to assess later. Your testing is going to be an optical coagulоmeter. So the best is your biochemistry remember has hundreds of samples all day. Just ignore the sample, take a neat one, which is non-colored. That is best.
So there's one more question from Dr. Ashima. She is asking to explain how to make a clot from plasma.
Okay. So remember your plasma was taken in a sample of citrated sample, right? So the blue cap. So when you spin it,